Good evening, everyone, and my name is Rafiz Kamalev, and we are starting the pharmacology lecture. Today's topic is drugs for diabetes, and drugs for diabetes are indicated for the patients with diabetes mellitus that can be the first type and second type. And the diabetes mellitus is diagnosed for because of the lack of the insulin production. That is because of the pancreas cells will not synthesize insulin at all, and the diabetes type 1 and then diabetes type 2, the pancreas will synthesize insufficient amount of the insulin. So, and insulin is synthesized with the beta cells of the Langerhans of the pancreas, and alpha cells will synthesize glucagon, and sigma cells will synthesize somatostatin. So today we will focus only on insulin because it's vital in the development of the disease.
Insulin is for type 1,
Yes,
for diabetes type 1.
yes, the insulin as a drug mostly used for the patients with the type 1 diabetes mellitus, and patients with the type 2 usually receive the oral hypoglycemic agents. So like that's mostly one of these agents listed in this uh, table. So insulin also can be different types, and then oral. So this insulin aspart, insulin determined, glargine, glulizine, lispro, and uh, neutral protamine hagedron, and regular insulin are indicated for the treatment of the uh, diabetes mellitus type 1, and for the patients with the diabetes mellitus type 2, the oral agents are indicated, including the sulfonamides, the meglitine analogs, biguanides, and triazolidinediones, and other agents. Also, amylin analogs that is also prescribed orally, and incretin mimetics are also available nowadays. So these are the mechanism of action of the uh, insulin is like the uh, after every time we take a meal, the glucose level of the blood is increased, and uh, this increase in glucose will lead to the increase in the insulin release in normal patients, like this blue chart. And then in type 1 diabetic patients, there is none of release of insulin at all. So no insulin, so it's always black. So, and then in types 2 diabetic mellitus, the release is not enough and uh, cannot actually utilize the glucose amount that is obtained from the meal. So there is no postprandial. So this insulin increase in the insulin release is called postprandial. That means after the meal. So, and the red one is actually so, and after postprandial insulin secretion, there is also a second wave that is smaller one. So this is a basal insulin secretion that is always synthesized to uh, despite the taking the meal. So type 2 patients, they have some basal secretion, but they don't have postprandial secretion. So that is why they are required to take the medicines. And the diabetes mellitus is a hereditary disease. So the presence of the grandparents with diabetes increases the chances for the disease and can be seen in young and old patients, and the disease cannot be cured, and the patient should take the medicines throughout the life. And moreover, type 2 diabetic patients usually become type 1 diabetic patients after about 5 years of the treatment. So that is why sooner or later all diabetic patients will require insulin injections, and also type 2 diabetic patients may require insulin combination with insulin and oral agents at the most severe cases. And the reason for the development of the diabetes mellitus is the resistance of the tissues to the insulin when the glucose is not uptaken by the tissues, mostly by the muscles. And also the second reason is the decrease of the release of insulin, or the absence of the insulin released by the pancreas. So these are the two reasons, and the insulin treatment looks like this. Like at the beginning, the patient can be treated with a diet, and then for the type 2 diabetes, at the beginning usually patients will require only metformin, so only one oral medication. Usually that is metformin because of the low adverse effect profile. And then 5 years later they will require second or even third medication, oral medication. And then in 5 more years, so in 15 years, they will require multiple injections of insulin, despite combined with the oral medication. So, and then they will be transferred to the type 1 diabetes patients that will require daily insulin injections, so with a high dose therapy. So the disease is increasing in severity, so it's progressing disease, and that is why the treatment should be taken very carefully, and check-ups should be, follow-ups should be managed. And there are several types of the insulin. So for the insulin sources can be animal insulin or the human insulin, and usually the regular human insulin is used for the treatment, and the regular insulin is Humulin, and is obtained with the engineering technology, and that is why it's less prone to the allergic reactions, unlike the insulin obtained uh, mm, from the pigs or from the cows. So these two types of animals are used for the production of the insulin, and because the amino acid sequence of animal insulin is different from the human insulin, and for example a pig insulin has one amino acid different from the human, and the bovine insulin has two amino acids different from the human. That is why they have allergic predisposed and can lead to the allergic reactions more frequently than the regular insulin. And moreover, because of these are obtained with the extraction from the pancreas, other proteins can be obtained from the pancreas as well, including the animal proteins that have a high adverse effect potential, including the hypersensitivity reaction. So, and moreover, in Muslim countries, mostly the bovine insulin is used, if animal insulin is used at all. So, still in many developing countries, the animal insulin is scrapped because of the low price, and also the regular insulin may not be available in all countries because of the high cost of the treatment. Despite the normal insulin, there is a short-acting insulins like insulin lispro and glulizine and aspart. So these are three insulins that are short-acting insulins, and they act fast. So this aspart or lispro and glulizine are in violet color here. So the duration of action is about 3 hours and up to 4 hours, but mostly 3 hours, and then they have a peak like postprandial insulin secretion, so like this one, and this is very close to the natural insulin secretion, and they should be taken just before or during the meal, or even or just after the meal, because they have fast onset of action. Unlike the regular insulin that is peak maximum is at the second hour and starts after 40 minutes. That is why insulin should be taken half an hour before taking the meal. So and then there is also intermediate acting insulin, that is neutral protamine hybridone insulin, is where insulin is bound with the neutral solution of the protamine amine that is releasing insulin slowly, and that leads to the up to 20 hours of insulin action. So can be taken twice daily for the longer duration of action. Less injections result in less adverse effects and also more convenient. And then also there is a insulin detamir, that is long-acting, and also insulin glargine, and these two are long-acting insulins that require only once-day dosing, especially insulin glargine, and these are long-acting insulins that duration of action is up to 24 hours. And adverse effects of the insulin therapy include most severe is hypoglycemia, and hypoglycemia is actually the results in the headache, anxiety, tachycardia, confusion, diaphoresis, that is sweating, vertigo, shaky hands, and also increases the appetite. That is why patients with the type 1 diabetes mellitus are usually overweight. with a high BMI, and also blurred vision and weakness and fatigue. So this is the symptoms of the hypoglycemia. And also there is a lipodystrophy and hypersensitivity. So lipodystrophy is the accumulation of the fat tissue at the size of injection. To decrease lipodystrophy, the injection should be made at different size and size should be rotated. Like today we are making injection to the right arm, tomorrow to the left arm, the day after tomorrow to the right leg, etc. So different places, so there is no lipodystrophy. And to decrease the hypersensitivity, the uh, uh, the uh, uh, the human insulin is recommended for the use, and also uh, the doses actually. So and the doses should be maintained, like the minimal amount of the dose should be maintained for to decrease the adverse effects, and also to increase the compliance of the patient. And there are different schemes for the insulin injection. So the most common is 3 times daily for the regular insulin and long-acting insulin at bedtime. So, and also long-acting at the breakfast. So the breakfast, actually the 2 types of the insulin can be combined in one syringe if they are compatible, because not all of types of the insulins are compatible in one syringe. So that depends on the manufacturer, and also you should check that with the manufacturer. Then there are also premix insulin combinations, like for example nitroprotamine hagidon long-acting 70% and regular insulin 30%. So these are already mixed by the manufacturer, so that is why can be used in one syringe. So they are specially stabilized to be able to use in one syringe, because it is one solution, so this can be taken twice daily. So this is more convenient way. This way is 3 times daily with the short and long acting at the morning and at the bedtime. Is less convenient, but is more efficient, because usually people have 3 servings daily, so at the morning, lunch and supper. So and that mimics the postprandial insulin secretion. So with this scheme, probably patients should take a small lunch or no lunch at all, and also there is a Lispro or short-acting insulin with the Detamir. That is, Detamir is taken once daily at bedtime, and Lispro 3 times a day before the meal. So these are the most common ways of insulin injection. Then the more frequent injections usually lead to less complications with the glucose level. Like the glucose level is more stable, and with the less frequent injections, the hypoglycemia and hyperglycemia are more common, but the less but there are less adverse effects, less complications by the cardiovascular complications are less. So Anyway, here we have complications, cardiovascular complications, because it's very frequent. And here we usually have the glucose level complications. So both are not comfortable and can lead, for example, the hyperglycemia can lead to the gangrenia, and also especially gangrenia of the legs and extremities, hands and legs. So amputation of the legs is a most common complication of the failure for the insulin treatment. So actually there are two types of intensive therapy, and with the high doses that will lead to the hypoglycemia, and standard therapy with the low doses that will lead to the uh, 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 that will lead to the diabetic complications like retinopathy and nephropathy. But these are long-term complications. So for the hypoglycemia, the complications are the short-term. So usually hypoglycemia will lead to the hypoglycemic coma, and that may result in death or the injury. So then there are also oral hypoglycemic agents that includes the sulfonylureas and glinides, biguanides, inhibitors of alpha-glucosidase, and then tizidinediones, and inhibitors of peptidase 4. Every of these drugs has a different mechanism of action, or they decrease the insulin by increasing the production of the glucose in the pancreas, or by increasing the utilization of glucose by the tissues. So these are two main mechanisms, two main approaches for the treatment of the diabetes type 2 patients with the oral hypoglycemic agents. All of them have adverse effects that are close, almost the same as the insulin. For example, hypoglycemia is very common, so the most common adverse effects that are usually seen in any hypoglycemic medication, including the insulin. And then GI disturbances are also common because they are taken orally, especially with the alpha-glucosidase inhibitors, because alpha-glucosidase inhibitors are not absorbed, and they inhibit the alpha-glucosidase in the intestine that metabolizes the polysaccharides to the monosaccharides, and that makes the absorption of the carbohydrates possible, and so usually in the form of glucose. And the inhibition of this enzyme will lead to the decreased absorption of the carbohydrates, and they will be released without absorption. And then most of the oral hypoglycemic agents, all of them except the metformin, increase the weight. So the patients will feel the weight gain. So that is particular common problem in women, especially old women. So, and they usually suffer from the weight gain because they have to reduce the weight to decrease the amount of glucose level. So studies show that exercises that decrease the weight like mild exercises for weight decrease, and also diet itself can be enough for the treatment of the type 2 diabetic patients. So without any medications. And even those who take medications will benefit much from the exercises and the diet. So diet is actually is a must for the patients. Any of these drugs will be not effective without a diet. And exercises also decrease the glucose levels, and because that increases the consumption of the glucose by the muscles. So that is all, more glucose will be consumed by the muscles and then will not stored in the liver, so that decreases gluconeogenesis. So the storage of glucose, and also will decrease gluconeogenesis further. So that is why weight gain is a problem and should be managed. And then actually metformin will sometimes lead to the nausea. So that is why those patients who take metformin usually lose weight because of the nausea and vomiting, and actually decrease the appetite after. And then actually dipeptidase 4 inhibitors lead to the pancreatitis. It is actually the newest drug available as oral hypoglycemic medication, and is not yet available readily in Russia. I'm not sure about Egypt, Algeria, and other countries. So that is it for the treatment of the diabetes mellitus. And if you have any questions or comments, then feel free to fill them below, and see you next week. Bye bye.